Okay, go.
Hello, Nursing 204 students. We're moving right along. Today, I get to talk about drains, which is very fun and exciting. They're kind of cool. So I've written on the board here some of the drains that you will be seeing out in the field, and we're going to look at them and talk about them. Unfortunately, I don't have every single drain here, but I'll explain them as we go along. So initially, we're going to talk about Penrose drains. Penrose drains are kind of like a rubber hose a little bit. There's a hole in the center. Oftentimes you'll see phlebotomists or nurses who don't have tourniquets for drawing labs use Penrose drains because honestly they're pretty effective that way. So as you can see, there are different sizes. So Penrose drains, they're usually used after a surgical procedure. They can also be used if there is like an abscess or something where there is needing to be drainage wicked away from the wound. So basically the way Penrose drains work are that if there is, say my hand is an open wound, so the doctor will put the Penrose drain in the bed of the wound. Sometimes I'll put a little stitch right at the exit of the drain from the body just to hold it in place. They usually will do that. And then after that, usually what you will have, this drain is pretty long, but anyhow, I'll fold it in half. There we go. So usually then what we do, what nurses do, what our responsibility is dressing changes. And usually then what you will do is clean the site, the exit site where the Penrose drain comes out of the body, and then put a gauze dressing, an ABD, over the end of the tube because this creates a channel for the fluid to flow through and out of the body. And having gauze or an ABD over that helps to wick that drainage out and remove it from the wound, most definitely. And it helps the wound bed to heal. So this oftentimes will be in place maybe for a couple days. And then because hopefully the wound is healing and granulating on the inside, because as we know, wounds heal from the bottom up. So then they will remove this drain to then allow for the wound to continue to granulate and grow new tissue and heal. So these are called Penrose drains. And when we have clinical lab, you can take a look at them. They're kind of fun and cool. They're stretchy little rubber bands. So next, we're going to talk about Jackson Pratt drains. So these are kind of funky. These are used where I usually saw them the most is if women had breast surgery, like a breast reduction or something like that, abdominal surgeries, hip replacements, knee replacements. If they were not real big and involved wounds, then oftentimes they'd use, it's a JP drain, it's called, or a Jackson Pratt drain. So the way these work, as you can see, I'll hold this close. This drain has multiple little holes there, and that creates an entry for the drainage. And then this is sutured in the body usually. And then what nurses' responsibilities are with JP drains. They're pretty fun. What you do is this bulb will collect the drainage. And what you do is when you compress the bulb, it will, if I can get this back on again. Hello. Okay. Thank you. So what you will do is compress the bulb. And as you can see, the bulb stays collapsed. And what that creates is suction inside the tube, and it'll help to suck the drainage out of the body and into this tube. It's not very strong pressure. It is just kind of a gentle suction You don't want to, some wounds, because of course you're wanting the tissues on the inside to granulate, you don't want to disturb that process. So you don't want to like hook this up to wall suction and crank up the suction. You want gentle pressure, and this helps to remove the drainage. So your responsibility, there are little markings on the bottle here, and it will tell you how many cc's there are if you're just doing a quick look. But also too, you can pour it like in a specimen collection container so you can get a more accurate output. But you'll usually see serosanguinous drainage in this. Sometimes there can be a blood clot in the tubing, so you may sometimes need to just gently squeeze the tube a little bit to help to move things through the tube. But oftentimes what can happen is the bulb can become inflated again, and sometimes that means that maybe there's an air leak or something like that. So you always want to kind of pay attention, check to see that you're definitely getting suction and that it's definitely functioning. Now then, I recommend, if it starts leaking, of course it's not really effective per se, so you might want to talk to the doctor and just let them know. Sometimes doctors will just let gravity fill up this bulb as well. So make certain that you're reading the orders to know exactly what the doctor is wanting for the suction, most definitely. So this is a Jackson Pratt drain. And my dear Karen just arrived with a little med cup. So this is great because as the wound heals, then the drainage becomes less. And so sometimes using a small med cup, because there's not a whole lot in there. And so you want to be accurate with your measurements. So you can just, whoop, you couldn't see that. Sorry about that. Okay. So you just squeeze the drainage into your med cup, and then you can read and see what your drainage amounts are, so that you know, and you can record this in the patient's INO records, most definitely. So that's a JP drain. Thank you.
Pin it to their gown. So
oh, yes. Karen brought up a very important point. Exactly. Thank you very much. So say the woman has had breast reduction or something like that. So this drain is hanging around their middle area, and you really don't want this hanging and pulling. You don't want the drain to hang and just pull and or be something that they trip over or it gets caught. So there is this nifty little plastic loop right here. I don't know if you can see that or not. It's a pretty cool little loop right there. Thank goodness they thought of this. And you can use a safety pin, and you can go through the patient's gown and go through this loop and pin it back to the patient's gown. And then the patient has the ability to be more mobile and move around, and this drain will not be pulling. And you want to pay attention. With all drains, you really want to pay attention to where they're located, what the patient's activity is. Is it going to get in the way of the patient moving around? You definitely don't want drains pulled on and pulled out early. Your surgeon will not be happy. Trust me. Maybe I've experienced that before, you know. It's never a friendly phone call. I'll say that. Next, Hemovac. So Hemovacs, these are usually for more, for larger surgeries. These I see more for hip and knee replacements. And they look kind of barbaric. They kind of are barbaric. So you'll see there's a stylet that's metal. That's sometimes because the surgeon is poking in through some tissue and all to get this tube in place. And this is interesting. This stylet should come out. Usually it goes into the wound and through the wound, and then with this, I guess with this one you can cut it off. Exactly. And there are little holes right here. I don't know if you can see that or not. It's pretty small. There are holes in the tube right here so that it has an open area to collect the drainage. Oh, that's a good thought.
I wonder if it works that way.
Can you see those little holes? kind of, sort of, but not really. Yes.
Yeah.
Now you see them. So these are great for hips and knees. They definitely create a whole lot more suction. Be careful of this stylet. Make certain that it goes in the sharps container so no one gets hurt, because it is, it's pretty. Whoa, here we go. Whoa. Oh, my stars. Am I real? Oh, this is backwards, folks. I apologize. Where are we?
Green dot. Green dot.
Okay. Oh, there it is. Whoa, thank you. Going for the, oh, I have to go clear for the green dot. As you can see, that bugger is pretty sharp. So be very cautious and careful after you cut off, after the surgeon cuts off this tip. Make certain you know where this stylet goes, that's for sure. So the way a Hemovac works.
Oh, nice. It has a clip.
It does have a clip. That is pretty cool. So what you do is, there's a clip right here where you can close it from the tube to the container, but you'll want to clamp it for just a moment. Then it has these little holes right here with a little plug. And what you want to do is you can empty it out.
I'm going to just put it right up here.
Oh, thank you.
There we go.
Oh,
You can
thank
see
you.
that?
Thank
You see that hole
Yes.
right there?
Perfect.
There you go.
Thank you. So you can pour out the drainage out of the Hemovac. You can pour it out through that hole. And then what you want to do is, and oftentimes I find just having the bed to push it on. I apologize. Things are opposite, so it's very comical. So you decompress it, push it all the way down, and then put that plug back in again. And well, we don't have an airtight seal because it's filling back up again. But anyhow, that is the way this that is the way this drain works. And if you can see really closely there inside, there are these metal springs, and they are pretty firm. You really do need to have a little bit of arm strength when you're decompressing them. I know, that little fucker. It's determined to fill up. So anyhow, you want to decompress it all the way. Or compress it, yes, excuse me. Compress it all the way, and make certain that it's as flat, compressed as possible so that you're going to get the optimal suction. Also too, as you can see, once again, they did careful planning. We have this little clip right here, which is great. Oh my word, I apologize. So you have this little clip right here, which you can open up. It pinches and opens up. And you can attach it to a gown or the patient's clothing. So, oh my, okay. There we go. Thank you, Karen. Oh, so T-tube. Unfortunately, I don't have a T-tube here. T-tubes, they are used for if someone has had a gallbladder surgery, had their gallbladder removed. What it does, it's literally at the end of the tube. It looks like a T. It has a T-bar, and it fits right in the bile duct. And what it does is it removes bile drainage and allows for that area to heal if they have removed the gallbladder. And it's usually only in there for like 24 to 48 hours usually, as a general rule. They just want to drain that bile drainage out so that it's not collecting inside. And of course, the body starts working to reabsorb that and everything. So it's usually a pretty temporary sort of drain. So this is a leg bag, but we're going to fake it. So a T-tube bag looks kind of like this. And there is an opening at the top, and the drain, the surgeon will put the drain in, and the liquid will, the bile drainage will drain into the bag. And then there's always an opening down at the bottom of the bag where you can drain out the bile drainage. Bile drainage is kind of a yellow greenish color. and there's usually an odor to it. Once you smell bile, you won't forget it. So anyhow, so this is a fake T-tube drain as we improvise. The next one I'm going to talk about is a Pleur-X drain. You honestly see this a little more in the home care setting, but oftentimes in facilities, you will see this as well. So this is a drain. Okay, thank you. So this is a drain that if the patient has pleural effusions, if you are trying to, and they have repeat filling of the pleural space, the doctor will insert a tube, usually under x-ray under fluoral. The doctor will insert a tube, and then the responsibility of the nurse is to empty the Pleur-X drain. Now then, depending on how often, how much fluid the patient has, I should say, depends on how often you drain it. Sometimes it can be every 24 hours if the patient has a lot of fluid that they keep producing a lot, and it keeps refilling in the pleural space. You may need to empty it fairly frequent or drain it fairly frequently. Otherwise, it can be up to 3 days. If there's not really a whole lot of drainage, oftentimes the doctors will make decisions about whether or not to keep the drain in or remove it, or remove the tube, excuse me. So how this works, the patient has the tube already placed, usually on either one of their sides, and it is under a sterile dressing. So when you open this up, you're opening up a sterile area. When you open up this container to complete the process, you are opening up and creating a sterile field. You want to pay particular attention in making certain that you are protecting the patient, most definitely. So how this works is this little device, it looks like a little plastic hard tube. There we go. Woohoo. Okay. Green dot. There we have it. So it's like a little plastic straw, and it fits right into the tube, right into the drain that is already in the patient. So you'll click that into the drainage tube, and you'll make certain that this is locked before, or clamped shut before you start doing this procedure. Then what you will do, this plastic piece right here removes. You take that out, and then what you do is unclamp this, and then this pushes down, and it's going to pop back up on me, but this is what creates the suction. You want to push this down, and then it will start draining the pleural drainage. Now then, this bottle only holds 1 liter, and you only want to remove 1 liter at a time. And why do you think that is? A liter is a fair amount of fluid to take out of a patient's body, even though it is in the pleural space. But the patients can have some reactions to removing that much fluid. They can get hypotensive. They can show signs of dehydration, hypotension, rapid heart rate. They can start having dizzy episodes, which then creates a fall risk. You need to pay attention to this because you definitely don't want to compromise the patient. You want to remove drainage to help them so they can breathe better, most definitely. But you really want to make certain that you're paying attention to the symptoms that the patient is having with doing this. So you don't want to have this drain too quickly. You can alter that by the level where you have the bottle. Some people, if the patient doesn't have a lot of drainage, sometimes people will just put the bottle down. Some people will lay a sterile drape on the floor and put it down on the sterile drape. But you can have it at different intervals. You're still sterile. You can stand and hold it if you want to, because it doesn't take an extended amount of time really to drain. But you need to pay attention to all those things. when you're doing it. And I highly recommend that you make certain that you buddy up with a nurse who's done this before, and they can walk you through this and guide you through this. So after you have drained this, literally you can pop this piece off right here, dump out the drainage in the toilet and flush it down the drain. They really don't want you to put all this drainage into a biohazard area. So dump the drainage in the toilet and get rid of it. And of course, what things are you looking for? You want to record the amount that's in the bottle, most definitely, date and time. Make certain that you include date and time so that it is known when you last did the drainage. Then you are going to redress the drain with a sterile procedure so that you are creating that sterile area and protecting the patient. That is huge, highly important. So that is a Pleur-X drain. And last but not least, the Espirit Drain. So the Espirit Drain is usually used for patients who have ascites. It's a peritoneal drain, so it goes in the abdominal area. And as you know, well, maybe you don't know. Sorry, no assumptions. If you have been around people who get edema in their abdomen, in their abdominal area, it's amazing how much fluid people can hold and how much you can't really assess it. It's one thing when they're edematous in their hands and their fingers and their feet and their legs. You can push on that and you can assess the volume of liquid. In the abdominal space, it's more difficult to assess. So sometimes it's hard to know how much fluid the patient has in the abdominal area. But anyhow, once again, I don't have an Aspira drain, but we're going to use a leg bag because it looks very similar to this. And what it is, the drain is already placed in the abdominal area, and you will connect the drain to the drainage bag, and then you can lay a sterile drape on the floor and lay this bag. This will be a sterile procedure, just like the Pleur-X drain. You'll lay this bag down on the ground. Now, once again, you want to pay attention to volume. So make certain that, you know, you have your bag at the right, have it flipped up the right way so you can kind of be watching to your volumes. But anyhow, lay that on the ground and then just give that time to drain. Pay attention. If it's coming out pretty quick, you might need to lift that drain up. It might even just lay beside the patient on the bed. But pay attention to that. You do not want to drain more than 1 liter at a time, once again, because you can definitely create problems for the patient, most definitely. So,
I have one thing.
yes,
One
please.
thing. Okay. So how to tell if it's an ascites? An ascites is when a patient is third spacing. So fluid from 1 or 2 or parts of the body are going to a space where they shouldn't be. And so that's called third spacing. And abdominally, you can tell if it's an ascites or if it's not. And the way to do that is to put your arm across the abdomen of somebody and then create a wave. And if that wave continues past where your arm is, so if the wave that you've pushed on the stomach, it's just a gentle pressure to push and create a fluid wave. And if it goes past where your arm is, that's an ascites. If it stops right where your arm is, creating that tension on the abdomen, then it's not an ascites. So just a little trick and a really cool way to know whether it is or not.
Thank you.
Yeah.
Good point. Absolutely. Absolutely. Thank you so much, Karen.
Okay.
So if you have any questions, email us, most definitely. It's really hard not having you here and having you raise your hands and ask us questions. So just know we miss you.
Yeah, we do. Yeah,
okay.
we do. All right. We'll talk to you guys later. Bye.
Bye for now.